everyone, I'm Dr. Lauren Dennelly, and I am here to answer some questions about harm reduction. So the first question is, what is harm reduction? Harm reduction interventions really allow the client to take the lead in making decisions towards change. So the main idea is really to help move the client further down on the continuum of harm from most harmful behavior to least harmful behavior and sort of anywhere in between that. So for example, you might have a client who articulates an interest in reducing their screen time. So you might develop an intervention where the client tracks, how many hours a day they're on screens and slowly tries to reduce that by 30 minutes, 60 minutes, 90 minutes, and so forth, with the understanding that they're not going to be off screens completely. The expectation isn't that they are abstinent from using screens completely, but rather that they reduce their time in a way that improves their quality of life. So relatedly, how can we apply harm reduction to substance abuse? So when we take a harm reduction approach to treating substance abuse, we're really attempting to remove shame and stigma that surrounds drug use and recognize that clients really deserve respect and have rights and treatment just like anyone else. Since the goal is really to move clients along the continuum from most harmful to least harmful or anywhere in between that, the idea is that the client will likely not abstain from drugs, and that is not a requirement for them to engage in treatment when you are using a harm reduction approach. So as a follow-up to that, a question that often gets asked is, does this mean we're saying as clinicians that we're okay with clients using drugs? No, it does not minimize the harms of substance abuse. That's not the goal. Most people who use drugs would wish that they didn't, would wish that their lives had turned out differently, would like to reduce their use, if not completely stop if they could. So the idea is just not to bring your own agenda to the work, but rather recognize that their path to improving their quality of life might be different than another person's path. So any change, any improvement, even very incremental, is worthy of support. Another question is, what are some barriers that clinicians face in providing harm reduction services? So one of those would be just rigid agency rules. So for example, supportive housing programs often require clients to be completely abstinent from substances in order to engage in treatment. There's really a significant lack of state and federal funding for harm reduction based programs such as safe injection sites or needle exchange programs. And our current drug scheduling in this country significantly limits our ability to study different kinds of harm reduction interventions. So if you're interested in learning more about harm reduction or sort of other topics related to ethics and risk, join us online at the Conference for Clinical Foundations, Ethics, Risk, and Duty of Care in 2026 from February 18th to February 20th.